of pediatrics, which reach about 90 to 95%. But what we have done to the adults is really beyond or below the optimal that we are looking for. So it has been calculated that we achieve only 30 to 40% of the coverage of the adults throughout the spectrum of vaccine that is required for the adulthood. So today we are going to talk about another important topic, which is herpes zoster. And we are going to focus on the vaccinations. And in fact, to tell you the story that we started in 2019, we started a campaign, national campaign, to enhance the perceptions of our people in the community towards vaccination, with a special focus on herpes zoster vaccine. We started in Jeddah and Riyadh and in Dammam, different campaigns. The last one, which was a couple of months ago, it was in the boulevard of Riyadh, and we secured the record of Guinness record for the best participation of the community and the perception of the community towards adult vaccination. So this was a great success that has been achieved by the collaboration of the Saudi Society for Family and Community Medicine and GSK Company. And today we are going to go for the second step, which is enhancing our capacity and capability as a physician to identify those patients at risk and to initiate the process of convincing those adults at risk to have the vaccine. So we're going to tackle the vaccine hesitancy, and we are going to enhance our capacity to have a vaccine recommendations. So today we are going to have a very rich session, in fact, and we have been privileged to have our guest speakers. They are representing different specialty. And we have Dr. Badr bin Hamd, Dr. Tarad Talmisani, and Dr. Rabia Abu Ala. They're going to talk about different aspects that will cover the whole subject of herpes zoster, from prevention to treatment, and even to different parts of complication of herpes zoster, post-herpetic neuralgia. So without any further ado, I would like to introduce our first speaker, Dr. Badr bin Hamd. Dr. Badr bin Hamd, he's a chairman of the Family Medicine Department in IMC, and he's the chief or the chairman of the Credential and Privilege Committee in the IMC International Medical Center, and a member of the Organizing and Scientific Committee for the Family Medicine Club and Conference. And he has the Saudi Board and Arab Board in Family Medicine and a Master in Medical Education, and a member of the International Association of Medical Education and a member in the Saudi Society of Family Medicine. He speaks an organizer, and he's an organizer in the International Family Medicine Conferences, and he has, in fact, a lot of contribution to our scientific sessions and event in family medicine when it comes to IMC. So now Dr. Badr, he will talk about the prevention and the management of herpes zoster in adults. So I would like to welcome here on board, and to know that we have been joined by 3,000 attendees as we speak now virtually. So I would like to ask those who are attending to prepare these questions and to put the questions in the Q&A box. So we will have a Q&A session at the end of these presentations. So Dr. Badr, the floor is yours.
Thank you so much, Dr. Ashraf, for your introduction. Good evening, everyone. Assalamu alaikum jami'an. So as we know, varicella zoster virus infection cause two type of diseases. The primary infection with the varicella zoster result in varicella, which is chickenpox. Herpes zoster is the second disease that caused by the same virus, and also known as Shingrix, which result from reactivation of the latent varicella virus that gain access to the sensory ganglion during varicella. Herpes zoster, as we know, is characterized by a painful vesicular eruption, which is usually occur in a single or two contagious dermatomes or more than that. So this is a typical picture of a herpes zoster patient, and this is the typical picture of the rash that we see in our clinic. Of course, we are going to discuss it more and more in the next slides. So once chickenpox rash develop, the virus, which is present only in the skin as the skin vesicles, is postulated to infect nerve ending in the skin to establish a lifelong latency in neuron within the regional ganglion. If reactivation occurs, so this virus can spread within the ganglion to involve multiple sensory neurons to establish infection in the skin and cause the typical rash. So following reactivation of the virus, okay, of the latent varicella virus that involved sensory ganglion typically exhibit intense inflammation accompanied by hemorrhagic necrosis. And this is mostly the cause or the reason behind the neuropathic pain. And the ganglion undergoes eventually what we call neuronal loss. Subsequently, there will be a fibrosis in these neurons, and that again is the reason behind the post-herpetic neuralgia. What about epidemiology? So in the United States, the herpes zoster occur in more than 1.2 million individuals annually, and the incidence is increasing with age, as we know, and it's worldwide is increasing, especially after COVID. Still, the reasons behind this is unclear until now, and of course, the investigation is ongoing. What about the risk factor? The main risk factor for herpes zoster is immune system. So what behind the immune system? So it's more likely to happen or to occur in immune suppressive patient. Of course, it increase with age, especially after 50 years. And this maybe will be more elaborated more and more and discussed with Dr. Trad in the next session. A patient with transplant, autoimmune disease. And just today, I had a patient with autoimmune disease with recurrent herpes zoster, and she's young, almost 30, 31 year old. So this is a risk factor, and she's female. So female is more prone to have this infection more than male. Of course, malignancy, chemotherapy, chronic lung and kidney disease, all of these are considered as a risk factor. Age, if we talk about the age, so age considered as the most important risk factor to develop herpes zoster. We are talking about dramatic increase after the age of 50. Of course, we start to see patients, even younger patients, even in 30 and 20 with herpes zoster. But of course, being a 50 or more than that, it doesn't mean you are elderly, but you are at more risk of developing, of course, herpes zoster infection. And the post-herpetic neuralgia, which is the main complication of this infection, is increasing more and more with age. What about transmission? As we know that herpes zoster or this virus is spread mostly by direct contact with the infectious vesicles, okay? And the most infectious period between the 7 and the 10 day from the start of the rash. Of course, they found that it is also available or present in the saliva, and this can be lasting for almost 15 days. People with herpes zoster can transmit varicella zoster even to naive patient causing chickenpox, but not herpes zoster. So the clinical manifestation, we can divide the clinical manifestation to two main clinical manifestations. Pain, which is the most common reason that bring the patient to your clinic, and the rash. Almost 20% or less, they have other symptoms, and we are facing this in our clinic. So the patient can come, and this could be an early presentation with headache, fever, malaise, and fatigue. Then after that, after 2 to 3 days, he will start to develop the pain, neuritis, and the rash. What about the rash? Let us start with the rash. So the rash starts as erythematous papule, as we can see here in the picture. And this typically can cover or affect a single dermatome or multiple dermatomes. And usually this is the same sensory ganglion where the virus was located previously. Then after that, these vesicles will group together to become bully, and sometimes it will cause what we call a pustular infection, as we can see here at the bottom of the slides. In rare cases, and this is one of the complications, which is herpetic ophthalmicus, this will be, we call this a hemorrhagic herpes zoster, and this is mostly more common in patient with or immunosuppressive patient with advanced age. So in immunocompetent host, the lesion crusted, as we said, between 7 and 10 days and are no longer considered infectious. So this is a reassurance for our patient. Scarring, hypo or hyperpigmentation considered as a risk, as a complication after the infection. So we need to discuss this with our patient. What could you notice after, having this infection? The development of new lesions more than a week after presentation should raise a concern of underlying immunodeficiency. This is the hypopigmentation, as we can see, as part of the consequence of the infection. And this is a hyperpigmentation. Simply how to deal with it. You need to reassure the patient, have a consultation with our colleague in dermatology, and most of these cases will resolve dramatically with good management. Although the rash can occur in any dermatome, still thoracic and lumbar dermatome are the most commonly involved. Of course, herpes zoster occur in the face in almost 10% of the patient, and some of the patients, they will have scattered. Like today, I have one patient, she had scattered. From every now and then, she has scattered herpes zoster, and we should think about viremia, herpes zoster viremia, and this should be, again, a consultation with our colleague in infectious disease. Another manifestation, which is a serious manifestation, which need an urgent referral to our colleague in ophthalmology, which is herpes zoster keratitis or ophthalmicus, and because it is a sight threatening. What about the second important presentation with this, which is acute neuritis, which is the main reason where the patient come to your clinic. So the pain is the most common symptom of herpes zoster. And I have one case, I will discuss it at the end of the presentation. Very interesting case. The presentation was about pain. So pain could be the only presentation, at least even in the first 5 to 6 days. Most of the patient will describe the pain, and this is again from our practice as a burning pain, throbbing pain, or stabbing pain, okay? And about 75% of the patient have prodromal pain that precedes the rash by 5 to 7 days. The prodromal pain sometimes will lead to misinterpretation of the infection. So sometimes the patient will come with a picture of cholecystitis, so pain in the upper quadrant region, or appendicitis, or renal colic, and so on. So it can mislead us. So the main thing here is a close follow-up for your patient. What about the complications? The main complication is post-herpetic neuralgia. So what is the definition of post-herpetic neuralgia? So it defined as a significant pain persisting for 90 days after the onset of rash. However, in some cases, and this is very important, post-herpetic neuralgia may develop months to years after resolution of the initial acute event. Do we have patients like this? Yes, we have some patients like this. This episode occurs in the same distribution as the initial rash and are typically precipitated by some triggers, okay, like surgical procedure or tooth abscess or other triggering factors. 10 to 15% of patients with herpes zoster will develop post-herpetic neuralgia. So this should be discussed from day one with the patient to reassure our patient and just for the patient to know what he could expect from this infection. Individuals, of course, it will happen more in elderly patients, and patients who receive the vaccine are less likely to develop post-herpetic neuralgia. That doesn't mean it will prevent the infection. That doesn't mean it will prevent post-herpetic neuralgia, but the pain or the infection could be less than if in comparison to those who didn't receive the vaccination. The pain can be burning, pruritic, sharp, or stabbing, and constant or intermittent. And we saw most of these presentations. And more than 90% of patients with post-herpetic neuralgia report allodynia. What we mean by allodynia, which is a sensation of pain evoked by normal, non-painful stimuli like light touch. So this is because inflammation in the neuron. We call it neuritis. On examination, usually there will be a normal examination for post-herpetic neuralgia. Sometimes you will find some scarring or excoriation because of scratching. And maybe sometimes we need to refer our patient once to the psychotherapist, or if you have the competency of, you know how to do CBT, very important to do it with your patient. Of course, the first step is to screen for an anxiety and depression for those patients. We know that chronic pain can lead to an anxiety or depression, so it's a very important point to be screened. The second complication, of course, it's rare. I saw it maybe in my career twice only. So herpetic ophthalmicus or herpes zoster ophthalmicus. What is the importance of this infection? Because it is a sight threatening, defined as herpes zoster involved the ophthalmic division of the fifth cranial nerve. The incidence is about 8% more or less, and about 50% of the patient experience direct ocular involvement if antiviral therapy is not used. That's why it's very important. Even if you want to refer your patient, please ensure that the patient will be seen at the same day. And if the patient will be delayed, like for next or next day or after 2 days for any reason, or he's traveling, please start the antiviral treatment, the oral antiviral treatment. Don't wait until he see his ophthalmologist. Sometimes the patient will not present with the rash, so he will present with like malaise, fever, unilateral paralysis and pain, and forehead and affecting one eye, and all of these could be preceding symptoms before the rash. The other complication, which is related to herpes zoster ophthalmicus, which is acute retinal necrosis. Again, the patient will complain of pain, blurred visions, and this again another complication that need an urgent referral to ophthalmology. So what is this? We call this Ramsay-Hunt syndrome. So here, as we can see, the vesicles is involving unilateral ear. It's a triad of ipsilateral facial paralysis, ear pain, and vesicles in the auditory canal or in the auricle. So this triad, we call it Ramsay-Hunt syndrome. The ipsilateral, sometimes there will be a taste or alter in taste perception and tongue lesions, and this is because of the involvement of the 8th cranial nerve. The facial paralysis with this syndrome is more severe than the paralysis with Bell's palsy. What about another neurological complication? So this is a rare cases, but serious cases that we need to pay attention to it. So patient can have or can develop encephalitis, myelitis, stroke syndrome, and all of this could be a complication of herpes zoster. Secondary bacterial infection at the site of the lesion, it's frequently seen with most of the herpes zoster patients, especially if they are scratching the lesion. What about recurrent herpes zoster? Is it common? Yes, it's common. And we are seeing patients in the clinic. Yes, just today I saw a patient. She's a female, 32-year-old with recurrent. She has a 3 episode. Annually, she is getting this infection. And after digging more and more in her history, she's a case of rheumatoid arthritis. So a young patient with autoimmune disease, okay, could have a recurrent infection. It's more common in women, okay? We should check for immunodeficiency. And of course, it's advisable to have a shared management with our colleague in infectious disease. Vaccination has place here? Yes, vaccination have place with those patients. What about the management for the acute presentation? So the most important question here as a family physician, can I treat? This is a question for us. Can I treat or should I refer? Can I treat or should I refer? Whether I'm working in a primary healthcare center or in secondary or in tertiary hospital. All of this depend on your competency. Are you competent enough to deal with those cases? It depends on the severity of the infection. It depends on the complication and the available facility in your center. So where and when to refer? So we can refer to dermatology sometimes if the diagnosis is unclear for us. We can refer to ophthalmology, as we said, in cases of neuritis, and if in cases of optic neuritis or ophthalmicus. In severe disseminated infection, especially in the elderly with immune suppression, sometimes the patient needs an IV of a cycloverse, so he needs to be referred to ER and admission. Pain clinic, sometimes we need for those refractory case or those not responding to the regular medication or pain control medication can have a benefit from referring to our colleague in pain management. And we'll talk about some modality that you're using in pain management. Neurology in case of the involvement of the neural system, like the complication that we mentioned, and ID consultation, of course, from time to time if we need. So what about the management? So the acute management has 4 pillars, antiviral, pain medication, vitamin B or B complex, and we'll talk about the evidence here, and antibiotic when it's needed. So we need to ask ourselves, assert some questions with each pillar. So with the antiviral, which one can be used? What is the optimal curative dose? What is the ideal duration of treatment? Because all of these 3 questions are the pitfalls or our mistakes sometimes in having not optimal or providing suboptimal treatment for our patient. What about pain medication? Should we start with antiviral directly, parallel with antiviral, or as a patient needs? When to start and what to give and for how long? B complex, is there any evidence about using the B complex or B12 with acute infection with herpes zoster? Should we use antibiotic as a prophylaxis, or should be used when there is any signs of bacterial infection? All of this will be answered in the coming slide. So whom to treat? So patient with uncomplicated herpes zoster immunocompetent who present in the first 3 days, they are a candidate to be treated. Antiviral therapy, of course, why we start in the first 3 days with antiviral therapy, because it will promote rapid healing of the skin, lessen the severity and duration of the pain, and potentially reduce the incidence or severity of chronic pain. This is all proven by evidence. What about patients who present after 3 days? So antiviral therapy is recommended in immunocompromised patient, elderly patient, those who are forming new lesions after 3 days. There is no benefit of antiviral therapy if all lesions have crusted. So what are the available antiviral? Just to be more practical, we have the famciclovir 500 milligram TID or valciclovir, which is mostly prescribed for our patient because the adherence is much, much better. So we are giving 1 gram TID 3 times a day, or acyclovir 800 milligram 5 times per day, rarely used nowadays. Topical acyclovir every 12 hours could be used. I like, this is my approach. I like to use topical and oral at the same time. Cyclovir, this is the drops. I will reserve this for our colleague in ophthalmology. The total duration should be between 7 to 10 days, average 10 days. Don't give medication less than 10 days. So it should be 10 days and above based on your clinical assessment. So valciclovir 1000 milligram 3 times daily or famciclovir are preferred because of their lower dosing frequency compared to acyclovir. For immunocompromised patient or patient with disseminated infection, IV acyclovir at admission could be an option. And after initial clinical improvement, patient may be switched to an oral agent if they start with an IV. Of course, this should be an under internal medicine after admission. It's not a primary care. You shouldn't do it in primary care setting, the IV acyclovir. What about pregnancy? Can we give antiviral therapy for pregnancy? Yes. The only proving safe antiviral medication in pregnancy is oral acyclovir. Of course, you need to consult the ID, dermatology, and of course, Herpes physician should be involved. What about the pain medication? Should we leave the patient without any pain management? No, because here we are talking about the quality of life. So what is the usual medication that we are providing for moderate to severe pain? Usually we are giving gabapentin with good dose, 300 milligram TID or 400 BID according to the patient tolerance. Pregabalin, okay, 75 BID. Dynamitriptyline and duloxetine can be considered with the patient. Should we add another medications? Yes, sometimes we can add another medication like topical lidocaine. I recommend for that, okay? Oral prednisolone, still there is no variable evidence about it. Non-steroidal paracetamol, very, very weak action for the severe pain, but you can give it. Tramadol, be careful when you give tramadol in severe cases, especially with elderly, and maybe this will be elaborated more with Dr. Turad because of the complication of adding tramadol with high doses for elderly patient. If pain is not controlled, please give the patient the benefit of referral to our colleague in pain management. There are many, many other modalities. These are an example of the medication: Urintine, Cymbalta, Lyrica, Mitriptyline, tramadol, and other medication. The new medication just introduced now in our hospital, which is capsaicin patches. Amazing medication, amazing patch that really can be used in the chronic post-herpetic neuralgia and can be used in acute phase after, of course, the resolution of the rash. And we have the privilege now as a family physician to prescribe it. Of course, the problem with it a little bit because it's expensive. The service is expensive a little bit, okay? The patient need to stay in a separate room at least for 1 hour for preparation, monitoring, and evaluation after we remove the patch, but it's so effective. Still, we don't have the experience with it with a Herpes zoster patient, but after discussion with our colleague in the pain management, they have some cases and the response is great with those patients. So the message here, the area starting the pain medication from day one, the better the pain control and the better quality of life. So we are talking about quality of life. Another message: pain medication do not prevent post-herpetic neuralgia. What about vitamin B12? So you can use 500 to 1,000 microgram once daily for 1 month or more. IM can be used, but oral is enough. There is no strong evidence about it in acute or chronic patients. There are variable data about the efficacy of B12. It could help from our practice and from our colleague practice. Yes, it could help, and further investigation is still needed. Antibiotic, another message, another important message: please don't use it as a prophylaxis, only if there is a secondary bacterial infection. What about the management of post-herpetic neuralgia? Almost similar to the acute management. So you can start with gabapentin, amitriptyline, Lyrica, topical treatment like capsaicin or lidocaine patches. All of these are effective and it's proven to be effective in our practice. Another medication that can be added like valproic acid, okay, or duloxetine and venlafaxine, all of these, another option that can be added. Of course, if you are competent enough to use it, you can use it. If you need help, please refer to neurology or pain clinic. For patient with partial response, here comes the other intervention that really the patient could benefit from it from the pain management. So oral or transdermal opioid analgesic and intrathecal glucocorticoid injection could help in severe cases with some patients who are not responding to the regular pain management medications. Interventional and surgical approach such as botulinum toxin injection, cryotherapy, neuromodulator, all of these other modality of treatment that can be provided by our colleague in pain management. Analgesic medication, as we said, paracetamol, ibuprofen, Voltaren, it has very limited effect or efficacy with our patient. Please don't forget to screen for anxiety and depression and provide CBT or cognitive behavioral therapy if the patient really need these therapy. What about the prognosis of post-herpetic neuralgia? So the pain may persist for months or years, and this should be discussed with the patient. And there is no definite way to prevent post-herpetic neuralgia. Again, this need to be discussed with the patient. Early treatment with antiviral medication can decrease the pain, and vaccination is the best way to avoid the infection, and it could decrease the severity of the post-herpetic neuralgia. Last part of my presentation was a case from the practice. Almost we saw this case 2 years back. He's a 50-year-old male patient, diabetic, obese, presented with progressing right upper quadrant colicky abdominal pain in the past 3 days. On examination, it was no rash, no erythema, moderate tenderness, negative Murphy sign. Antispasmodic medication was given to the patient. It was, we thought it could be a cholecystitis, beginning of cholecystitis. Ultrasound abdomen was done. It was negative, only fatty liver. So he came 2 days later with increasing pain, but the nature of the pain changed. So the pain became more burning in sensation. Still, there is no rash. Paracetamol at that time, muscle relaxant, B12 was given with follow-up 2 days. Mostly the diagnosis was it was a neuromuscular or neuropathic pain. So then after that, he started to develop erythema only at the site of the pain. At that time, we diagnosed him with herpes zoster, provided that there was no a single vesicle. So like this is the picture after almost 6 to 7 days. Okay, so after diagnosis, after we start the treatment for the patient, even if it was late and after 3 days, okay, still the patient benefit from the treatment very well. And he responded very, very well, alhamdulillah. So take home message, chronic pain due to post-herpetic neuralgia is a major medical and social issue. Failure to meet patient expectation can affect the patient life and affect the doctor-patient relationship. We need to improve pain assessment and document the physicians and nurses in each visit. So documentation and pain score is very, very important. And now it's become electronic. Don't hesitate to refer your patient to an expert in pain management if you don't have the facility or you are not competent enough to use certain medication. Understanding and feeling the impact of herpetic and post-herpetic neuralgia pain is the cornerstone of the management. Herpes zoster is not a rash. We should remember this. It is not just a rash, but it is a disease that can change the patient's life. Patient comes to you mainly not because of the rash, but because of the pain. And this is the missing ring. If you miss this ring, you will miss the patient. And the patient will start to do shopping between doctors, from one doctor to another doctor. So please, you need to take care about the pain as number one. So our role as a primary healthcare physician, as a family physician, is early diagnosis, early treatment, early referral when needed. And remember, please, that herpes zoster, the impact is not only physically, it is physically, psychologically, socially, and sometimes financially. And finally, remember that herpes zoster, treating herpes zoster, by treating herpes zoster, you are preserving and improving the patient quality of life. Thank you so much.
Thank you so much, Dr. Badr, for this wonderful presentation. You have highlighted the landscape of herpes zoster, identifying the population at risk and showing us how we could diagnose and manage and refer, and then finally how to treat the post-herpetic neuralgia. So this is exactly what we have to have as a competency as a primary care physician when we come in encountering a patient with herpes zoster. So now, ladies and gentlemen, we will move to the second speaker, who is Dr. Tarad Telmisani. Dr. Tarad Telmisani, he is a consultant in family medicine and geriatric, assistant professor of family medicine and geriatric at Al-Baha University, American Fellowship in Geriatric from Oklahoma University, and American Board of Family Medicine from Texas University, and Clinical Research Fellowship in George Washington University as well. So now a different topic from different perspective. He's going to shed lights on the healthy aging and herpes zoster vaccination. So another interesting topic to go. Thank you so much, Dr. Tarad, to be with us here today. Please.
بسم الله الرحمن الرحيم والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. Good evening, everyone. First, I want to thank you all for being here tonight, either physically or virtually. I'd like to thank the organizing committee for inviting me and the GSK for sponsoring this event. So today I'm going to be talking about herpes zoster in terms of sitting or the theme of older adults. And when I start any lecture, I usually tell a story. Maybe some of you heard that story before, but I have a special interest in home care. And a year ago, I was called to see a patient at home. I went to see this patient and I found a 90 years old gentleman, Saudi, but he's not like any other older adults I've seen before. He's very unique. Even though he's a Saudi, he lives in Europe, very well established. And I saw him for the chief complaint of back pain. So usually when I do a geriatric comprehensive assessment, I take a long time taking a history because geriatrics is different. And usually patients present with a very long history of conditions and they take a lot of medications. But this patient was different because he's very active, very independent, 9 years old. Until last week, he would ski down the mountains in France, do snow skiing. And when he's in Jeddah, he would swim for half kilometer every day. Very unusual. So I went to see him, and while digging more into the history, I realized that he saw a very prominent pain management doctor in Jeddah in the same day in the morning for the same complaint, who prescribed him some muscle relaxants, paracetamol, and lidocaine patch. But when a 9 years old say that this pain is different from any kind of pain I suffered in my life, this means that there is something wrong. I tell him, I have two theories. The first one, I would agree with the pain management doctor, and I would say that this just a musculoskeletal thing going on. The other theory is that this could be herpes zoster. But let us do the examination and let's see what's going to come up from there. So when I examined his back, pressing on the paraspinal muscles, there was just a tender, no rash, just a tenderness and the lumbar level of the paraspinal muscles. And I told him, you know what, I would agree with the pain management specialist. 3 days after that, the rash started and they sent me a picture of the herpes zoster. The moral of the story that this patient saw two consultants, and both of us, we missed the diagnosis. Even though he's very well established, but he didn't receive the care that you would assume in Europe of receiving the vaccine. Because I asked him why you didn't get the vaccine since it's available over there. Herpes zoster is very tricky. And as Dr. Badr mentioned, the quality of life, for me as a geriatrician, number one, the level of the independence of my patients and the quality of life is my first priority. So as I go in the lecture, I will give you some information, more information of what happened to this patient. Okay, so this slide just shows how does the virus, I mean, studies shows that most probably more than 90% of people who are 50 years or above, they do have the virus in the dorsal ganglia because of the chickenpox. And it stays there inside the dorsal ganglia for many, many decades until we hit the milestone of age 50. And that's when our bodies experience something called immunosenescence, which is the natural decline of the function of our immune system. That's when the virus gets reactivated by many reasons. Could be psychological stress, physical stress, or emotional stress. But the age by itself, age 50, is the milestone as an unmodifiable risk factor can increase the chance of the reactivation of the virus from the dorsal ganglia. Okay, so from Kitts et al., BMG journal, they published this data, 2014, showing that globally, citizens of the world, when they hit the milestone of age 50, for some reason, the incidence of herpes zoster start to kick, and it increases over the 60s or 70s, and it plateaus at the 80s years old. The graph on the right shows that as we get older, and if someone suffers from the herpes zoster, the chance of suffering from the most common complication of postherpetic neuralgia will increase along with age. Okay, Dr. Badr also explained the different phases of the disease. So the prodromal symptoms can be, you need to have very high level of suspicion for the disease, especially the burning sensation. This patient described a burning sensation which was a good indication for that, but we didn't see anything that could be a possible trigger for the disease. So the patient, when they sent the picture of disease, already started a valcyclovir. And studies shows that for patients, especially the elderly, when they start such a medicine, even though it's 3 times a day, their level of compliance is not ideal. And the level of mistakes that happens in terms of the dosing is very high. They can mismanage taking the medicine in time or the proper dose up to 50%. So it's very significant. And actually, this is what happened to this patient too. So I prescribed the medicine. I wrote down it's 1 gram TID. And unfortunately, the tablet comes in a 500 milligram form, and they only took 1 tablet instead of 2 tablets in the timely manner. Okay, so up to 30% of patients may develop the postherpetic neuralgia, and the same definition as Dr. Badr mentioned, 90 days or more after the subacute phase. If the pain persisted, this is considered the postherpetic neuralgia. Okay, so this is the dermatomal usual most common site is the trunk, the chest, and the abdomen of 56%. The cervical and the head and neck take the majority of that after the trunk area. So patient reported in several studies that the highest number of how they describe this pain, up to 76%, is hot and burning. Other patients would report the stinging pain, less percentage, up to 60% boring stabbing pain. A study was published, looked into how severe is this pain, and they used the short survey of McGill University for pain questionnaire. And the herpes zoster was just a little bit above the labor pain in terms of severity. and the postherpetic neuralgia was above the atypical facial pain. And again, with geriatric, everything is different because of their physiological decline that happens. The geriatric brain is vulnerable to a lot of things, and one of them is pain. So when an older adult suffer from a very severe pain like this, they may get pushed into delirium because of that. And the studies showed that the quality of life get impaired significantly because of that, mostly sleep. So if you have someone who's in his 80s or 90s and suffer from this such a pain, and here comes the other problem that even the available pain medications that we can prescribe to those patients, um, they have a lot of side effects. So when you say, and this doesn't apply to patients who are 60 years or less, but 60 years, 65 and above, they may suffer from the side effects of gabapentin, pregabalin. Amitriptyline is a big no in geriatric because of its very severe anticholinergic side effects. So we have limited options for the geriatric patient. So you are in your 80s, you get this severe pain, you cannot sleep, you cannot enjoy your life. It will impair your quality of life big time. So for this patient, we try to give low dose of pregabalin because the patient been in pregabalin before during his 70s, and he tolerated the medication pretty well. But even though the pain didn't get controlled, so we increased the dose from 75 milligram up to once a day up to twice a day, and his sleep was affected. So I was thinking, what can we do? So I sent the patient back to the same pain consultant he saw the first time. And I told him, listen, with this patient, we gave paracetamol and it's not effective, but this is the safest medicine that we can give. We gave pregabalin, but I don't think that this patient's gonna improve or have a good night's sleep. And I'm afraid that he will be pushed into delirium because of that. So he gave him Botox injection as a nerve block, and that helped him better than, not to take a systematic medicine and give him the side effects. So that helped him. Okay, so a little bit about the complications again. So the postherpetic neuralgia pain is the most common. Then we have between 10 up to 15% that the postherpetic neuralgia or the complication that happens in the eye and the face involving either the second nerve, the third nerve, or the ophthalmic branch of the trigeminal nerve. Okay, so again, the incidence would increase as patient gets older. So the complication rate will be higher and higher as they get older. So, but one thing about the patients who already have an immune compromised system, those patients will develop multi-dermatomal disease. So 2 or more dermatome distribution. It can happen both sides, right and the left side. They may suffer from the disseminated disease and they may develop the necrotic rash. So again, regarding the recurrence, it happens in a study that looked into 1,125 patients. The recurrence rate was up to 6.41% for those patients, and it is higher, most frequently observed in patients who are immune compromised. Okay, but since age is an unmodifiable risk factor, is there any other risk factors that may increase the chance of reactivation? After the pandemic, we all noticed that there is an increase of herpes zoster cases coming into the clinic. And according to the data from Medicare and Medicaid, they found that patients who suffer from COVID-19 and they get just sit at home and get treated for that, they had a 15% increase of reactivation of the virus. While patients who get admitted to the hospital, they had a chance of developing herpes zoster up to 21%. But beside that, so older adults, they have a very long list of comorbidities and chronic diseases, and they take a lot of medications. And each one of those each and every one of those conditions and disease comorbidities will increase the chance of the reactivation of the virus. So I'm gonna look into three conditions: the asthma, diabetes, and the cardiovascular disease. So a study was done and was published in the Open Forum of Infectious Diseases. They looked into the association between the virus reactivation, having herpes zoster, and whether or not different comorbidities can increase that chance of reactivation. And they found that patients who suffer from depression, they have the risk ratio of 1.23, so almost like 23% increase of having herpes zoster. The same thing for asthma and diabetes, but patients who suffer from COPD or cardiovascular disease, it went up higher in that rank. And of course, patients who suffer from physical trauma were the most. Okay, looking into asthma. So a study that was published by Mara et al. In 2020 looked into that. And the risk ratio was up to 1.24, so 24% increase. And with that, they also found that among people who have herpes zoster, the chance of developing the complication of post-herpetic neuralgia was up to 21%. So the problem is that these factors, if you have a patient with a long list of comorbidities and condition, the chance of having herpes zoster, a reactivation of the virus because of the immunosenescence, will be higher and higher. So it's a compounding effect. If the patient have a very long list, very long list of conditions. So the recombinant zoster vaccine that was approved by the Ministry of Health, Saudi FDA, in Saudi Arabia, that it's available. The manufacturing company, they looked into as a subgroup analysis in terms of conditions and diseases. They did two big 3-phase trial, the Zoe 50 and the Zoe 70, and they found that for patients who received the vaccine, they wanted to look into how effective is the vaccine in patients in terms of their comorbidities. So in patients who suffer from the asthma, the vaccine was effective by 88.8%. And of course, this is a list of all different conditions, but the one in the orange color indicate the results for the asthma. Looking into diabetes, so a lot of studies too have been done regarding that, and the average of having reactivation because in a patient who is 50 having diabetes alone is way much higher. So, but we can put an average on the percentage of adding risk for the reactivation to be between 24% up to 60%. And of course, as we all know that diabetes by itself will affect the immune system other than having the immunosuppressant process going on. And the chance of developing the complication of post-herpetic neuralgia for those patients will be up to 25%. So in the same study, the Zoe 50 and Zoe 70, they looked into the patients who received the vaccine and they were diabetic, and the vaccine efficacy was up to 91%. Looking in patients with cardiovascular conditions, a lot of studies been done. So a meta-analysis was also been published by Mara et al. In 2020, looked into that specifically. And the chance for patients who have cardiovascular conditions to develop the reactivation and herpes zoster was 34%. Okay, how was the vaccine effective for those patients? It gave them an efficacy percentage up to 97%. So in summary, herpes zoster, as we see with Dr. Badr, will affect the older adults' quality of life because of the reactivation of the virus. The immunosenescence and the different comorbidities of those patients will play a big time in the reactivation. And it is very difficult to control the pain in those patient population because of the different side effects of the medication that we can prescribe. So we need to go through the channels that Dr. Badr mentioned. I referred the patient, I mentioned the story to the pain management to help with that. And now we have a vaccine that is available, the recombinant Zoster vaccine. And I'm very happy to see that it was picked up very well by the population. But the main issue is that even though patients receive the first dose of the vaccine, according to the data from the MOH, unfortunately, most of the patients do not get the second dose of the vaccine. And so that requires from our side to remind our patients about the importance of taking the second dose in order to get the full protection from the vaccine. Thank you very much.
Thank you so much, Dr. Tarad, for this wonderful presentation, shedding the light on elderly aging populations and the risk of having herpes zoster. And now we are going to have Dr. Rabia Abu Layla. He's a family medicine consultant. He's a director of the first clinic of IMC in Jeddah, graduated from American University of Beirut, Master of Health Administrations, and Certified Professional Health Quality Lean Six Sigma. So he's going to talk about the herpes zoster vaccinations in general, with a special focus on elderly populations again. Please, Dr. Rabia, the floor is yours.
Assalamu alaikum. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. In this section, we will focus more about the vaccination, the herpes zoster vaccination. Basically, we'll highlight the efficacy and safety in adult above age of 50 years of old, and how incorporate the vaccine in our clinical practice. Just I want to stress on one thing, that shingles is a preventable disease. So basically, we cannot refer. It's our duty, our call. As family medicine, it's essential, and they have pivotal role in preventing such disease. We cannot refer the patients. So basically, it's our role to prevent the acute presentation, to decrease the complication, and to prevent recurrence. It's our role to improve the quality of life of the patients. It's our role to boost the immunity of patients above age of 50. This is our call. If not us, who will do it? So basically, this is a nature. Patient above 50, the cellular immunity declines with age. So basically, we will get it. So we have to make a move and help our patients and start to offer them the vaccine. What to do with the nature? Shall we give up? Or we have to do something? We have something. We have vaccines specifically designed to overcome the age-related decline immunity. We have it. We have the vaccine. Now, what the vaccine? Basically, we have glycoprotein. What's your name? Glycoprotein E, which is the most abundant glycoprotein at surface of varicella virus. It's expressed during herpes zoster episodes and target the humoral and cellular immunity. So we have a glycoprotein E. So is it live vaccine? It is not. It's not live vaccine. So we can use it for any age. This glycoprotein, we attach this glycoprotein two things: traditional components and immune modulators. They called it subunit, which is liposome, QS21, and MPL. These are subunit attached to this glycoprotein. The purpose of this, to elicit the immunity and to have long-lasting immunity. So we have now technology called recombinant subunit non-live vaccine. They have studied this, and we have an article that published in the New England Journal of Medicine in May 2015, efficacy of adjuvanted herpes zoster subunit vaccine in older adults. In this study, it was a randomized controlled study. It was mentioned by Dr. Tarad, ZOE 50 and ZOE 70, randomized controlled study, involved around 30,000 patients. The participants were certified into 3 age groups from 50 to 59, from 60 to 69, and above 70. Subjects above 70s were distributed in the group above 50 and above 70. And they did at the end pooled analysis to see the efficacy of the vaccine above the 70. The primary outcome was efficacy of vaccine against herpes zoster and the incidence of post-herpetic neuralgia and other complications. And the results were very promising. Look at this. We have the vaccine delivered around 97% efficacy against shingles in patients above age of 50. 97. Look to numbers, all of them above 90. Look to this number, the pooled analysis. Above 70 is 91, 70 to 79, 91. Above 80 is 91. We have vaccine, an effective vaccine. So, but do you see 100 here? No hundreds, correct? Only 90s, correct? So still, we took the vaccine, still we got the infection itself. So what will happen if I have the vaccine and I have the infection? What will happen? So this will go for next level, the complication. Look to the left graph here, the vaccine efficacy against post-herpetic neuralgia. The incidence has decreased around 91% for age group more than 50 and 88.8 for age group above 70. So it's very effective. So it's effective in decreasing the incidence of the primary infection and effective decreasing the post-herpetic neuralgia. And about other complications, also decrease the incidence around 93.7 for age group above 50 and 91.6 above 70. So again, it's very effective. So the only duty we have just to offer the patient, to tell the patient about this. So what about long-term? So now we have effective and efficient vaccine, and we have to offer the, what about the long-term effect? Is it 1 year, 2 years, 3 years? According to this report, was published in an open forum infectious disease, a brief report, after 10 years from administration of the vaccine. They checked how much effective or efficacy of the vaccine. And this 81% at the year 10, still effective, still efficient. And the average of efficacy is 89% across the 10 years. So still it's long-term. So we have two things now. It's effective and long-term, especially in elderly people. So what about the safety profile? Is it safe? Does it have side effect? Yeah, it may have side effects, mainly local reaction, pain, redness, and swelling. The general reaction is the common, and but very, very low. Still, it's a safety profile. It's considered safe. Now, regarding the recommendation, previously we were talking about diabetes, COPD, and asthma. We concentrate about comorbidities. Yes, right. These people, we should take care of them. But what about general population? Now the new recommendation is for general population. All people above 50 should take the vaccine. And this is from Saudi Arabia Ministry of Health. And the other committee also recommending for general population. So any patient come to us above 50 is candidate for the vaccine. It's not only diabetic, not only asthma, not only COPD or those who has a chronic disease, all of them. And this, as Dr. Talat mentioned, this is mainly for the diabetes or the recommendation across all committees for diabetes, specifically for diabetes, don't miss it. How to incorporate the vaccine in our clinical practice? It's easy. Once, as I said, once we have patient above 50, put it as a system reminder, we have to offer this. Now we have a lot of things to offer to the patient, but just put it as a priority. It's easy to administer to the patient. Just I want to mention this slide, adult 18 years of age or older increased risk of herpes zoster, like the diabetic patient in 18 years, asthma patient, 18 years. So you have to offer them, not only 50 years. So keep in mind that patient who has increased risk, we have to give them the vaccine. It's intramuscular, not subcutaneous vaccine. Is it 1 dose or 2 doses? As Dr. Sarah said, it is 2 doses. 2 doses of vaccine generated 4 times increase in cellular immune response versus 1 dose. It is 2 doses, not 1 dose. So from beginning, tell the patient you have to take 2 doses. Today, first dose, and after 2 months to 6 months, the flexibility, just to ensure the flexibility, you have to take the second dose. So it is 2 doses. What about co-administration with other vaccine? We are offering not only varicella vaccine. We have influenza, pneumococcal, we have Tdap. What we have, the co-administration doesn't have any problem. No safety issue raised, and we don't have any problem with us. You can give together. The vaccine is currently approved in 48 countries, 78 million doses distributed as of Q2 2022. Yes, I want to say here, shingles is a preventable disease, and we have to do something for this. This I want to say, it's designed to overcome decline in immunity due to the age, and it has long-term effect. And the only contraindication, hypersensitivity. If patient got hypersensitivity or anaphylactic, you shouldn't give. The others, it's like still pain, rash, still you can manage. Thank you.
Thank you so much, Dr. Rabia. And now, ladies and gentlemen, we would like to open the floor now for the questions, and I would like to invite the guest speakers to sit here and to receive the questions. So we'll open the floor before we go to the virtual attendees. So we'll open the floor here in the hall. Anyone has a question? Okay, come on. So we have 1,000 attendees. Do we have any question here? أي أحد؟ Okay, so we'll go for question there. Yes, Ken. Mike, please. Mike. Mike. Mike, give him a mic here. ما في واحد تاني؟ رحمن.
Hello, Assalamu alaikum. It has been a nice lecture. My question is regarding local or systemic steroid on post-herpetic neuralgia. So data doesn't support, but classically we have been giving. Role of systemic or local steroid, topical steroids for the outcome in reference to post-herpetic neuralgia.
Okay, thank you so much for this question. So I will give my feedback regarding this, and I will leave the other answer from my colleagues. So the evidence is variable about the oral. Before, maybe like 10 years back, it was like the routine management is to add the oral steroid, oral prednisolone for the patient. With any patient with post-herpetic neuralgia or even with the acute phase, is no longer recommended now. Is no longer for certain patient, and I believe this is still an old practice, and there is a lot of variable evidence about it. So the strongest recommendation is not to give the oral. But regarding the local injection, yes, it is part of the pain management for certain cases, those who are not responding to the oral pain management. Yes.
Okay, thank you.
Any other questions?
Thank you. So also, when you look at the guidelines concerning the corticosteroid treatment, you wouldn't find the specified dose, even though from the expertise point of view, some of them do recommend steroid in order to decrease the inflammation, the severity of the disease in some of the patients. So it's selected patients, group of patients where you can administer it. Still no specification about the dosage. Even if you check the articles concerning that in UpToDate, they wouldn't specify. So they will usually leave it to the clinical judgment of the treating physician, but it can help with severe cases for sure.
Okay, there is one question from the audience. I think for anyone, we know, Dr. Badr, maybe you can answer this question. Herpes also take place as a reactivations of the chickenpox. So how about those who did not get chickenpox during their childhood? How likely they are going to have a herpes zoster, and what is the source of that herpes zoster?
Still, there is no specific data about this. Up to my knowledge, there is no specific data about this. Of course, those who get the infection, could be more prone, especially nowadays. Those who the children who receive even the chickenpox vaccination. There is a controversy data regarding the percentage of reactivation in comparison to those who didn't even have chickenpox in their life, and they are elderly now. So there is a variable data about it, but what we know that it's all about the immunity. It's all about the immunity. If the immunity is becoming less because of any certain diseases or chronic condition or immune suppressive diseases, okay, or smoker patient or patient with autoimmune disease, and of course, elderly, this is by itself a risk factor. Whether the patient has chickenpox before or not, whether the patient received the vaccination for chickenpox. So still there is no specific data who is more risk to get the infection, but we believe that the infection could happen in anyone, okay, based on the immunity and according to the age of the patient.
Okay, thank you. How likely is the active lesions will be a source of transmission of the infection through the contacts, Dr.
I think it's about like when they become like a crust, and become dry lesions, will become not infectious anymore.
Mm-hmm.
It lasts like from 5 to 7 days, and then will become a crust, will not have infectious.
Okay. Dr. Tarad, our aim as a family physician is to have the early diagnosis to have a better outcome. So usually we diagnose herpes zoster once we see the lesion, but there is an area before that where the patient experiences a burning sensation, certain dermatome. What will be the tools to identify at that particular stage, and what could be the differential diagnosis of this kind of burning sensation, even before the lesion or even after the lesion?
I think we need to go back to the basics in order to reach a correct diagnosis by taking a good history.
Mm-hmm.
So it is a clinical diagnosis, and when we learn that there is prodromal symptoms that the patient may suffer from, and the criteria of the pain, burning, stinging pain, that sometimes some of the patients complain from abdominal pain along with that. But it is difficult sometimes. So having, let's say, a mindset of developing positive predictive value in terms of the symptoms that the patients comes with. So, okay, this patient have multiple risk factors and he's complaining from this weird pain that should bring the differential diagnosis for herpes zoster little bit up in the list. It is difficult, but we need to have this level of alertness, unfortunately.
Well said. Regarding Dr. Rabia, the question is, after infection, how long we should wait for the patient to receive the first dose?
After primary infection.
Yes, after the primary infection. There was,
Sure. I'm
two-
not sure
two
about
months,
the duration after the infection itself.
usually we
Yeah,
wait
there's-
for 2 months.
Yeah, there is no specific data, but
To schools.
mostly from the practice and from discussing many cases with our colleague in infectious disease, minimum 2 months, okay, up to 6 months, but minimum 2 months. Don't give them the vaccination before 2 months. This is the recommendation. Yeah, and if they are afraid that there maybe will be a flare-up of the infection. But this is the current practice, but there is no strong recommendation regarding this. For 2 months, I believe this is a practical duration or a safe duration to give the first or the second dose after the first or even the recurrent infection for any patient.
Okay, thank you. Dr. Rabia, you mentioned elegantly here in the presentation that the vaccine is safe. And at the same time, it has, it's efficacious in giving a 90+% of immunity. But how about the durations of the immunity? You said it's 10 years, but what happens after the 10 years? Do we need to have another booster dose or another vaccination?
According to the study, it's in interim analysis. It's
Mhm.
10 years, like last year, and it will finish after 2 years.
Okay.
We will have another analysis after 2 years.
Mhm.
So far, it is efficacious, more than 81%.
Yeah.
And we will have another report after 2 years from them.
So we'll wait for the reports. Okay, perfect. Any other questions from the
One
audience?
question, one patient asked me today,
Mhm.
is there any test that you can provide me, Dr. Badr, just to know whether I'm immune or not?
Mhm.
Because I had 3 infections.
Yeah.
So you should measure my IgG or measure my antibodies or so on. So again, there is no strong evidence to do that, whether it's accurate to measure it or not. The same debate and the same discussion at the COVID time, maybe in 2022, 2021, okay? What's the benefit of measuring the antibodies? So the high antibody that or high titer of the antibody mean that you are having more immunity and you don't need a further dose of the vaccination. Still, all of this debatable, and there is no strong evidence about it. And I believe the missing link in the management of diabetes, Dr. Ashraf, is not the diagnosis itself. Maybe there will be like sometime delay in the diagnosis, but what we notice from the practice is the suboptimal or the treatment inertia in treating the patient. Maybe we need to break the ice, okay, toward giving the patient very good and proper dose, okay, and proper duration. Because once you give like half the dose or less duration, so this could be a cause for recurrent. And the second thing, don't be afraid to give good dose for the pain management to control the pain for a patient. Of course, we need to consider other risk factors, the age of the patient, the delirium, and other complications, but close follow-up with the patient, having a documented pain score, and we have all the tools to do it now. This is, I believe this is crucial in treating your patient. So pain is number 1, rash and physical number 2 in the management, in my opinion.
Okay, thank you so much. Any additions? All right, so just to close the session, I would like just to reinforce the concept and the main important points that we have said. Herpes zoster is a common problem that we encounter in a very specific group of populations, our elderly patients with comorbidities, immune-compromised patients. These are the patients who has to be our focus when we look into them during our practice day to day. And once we diagnose and taking a proper history will tell us exactly what could be the prodromal symptoms that we can early diagnose the condition even before the skin rashes. And when the skin rashes comes, we have to be prompt in the treatment using the proper antiviral and the durations and even the strength and the dosage is very important. Look into the complications, the possible patient who might complicate not only with postherpetic neuralgia, with other serious complication. And this will be the point where we can refer patients to our colleagues in different specialty like dermatology and infectious disease and even neurology. And again, postherpetic neuralgia is one of the challenging, problems, and it impaired the quality of life of patients. But again, we have certain medications like pregabalin, gabapentin, duloxetine, tricyclic antidepressant, and so forth, as mentioned by Dr. Badr. And again, we have at the end of the road, we have the ultimate choice for us to do preventions rather than to get in the dilemma of treating the complication is using the vaccination. So all of us, we should promote and we should be advocate for the vaccine, especially for all the people who are encountered by us at the age of 50 and above. So the vaccine, as has been highlighted elegantly by all the speakers, with a special focus of Dr. Rabia, the vaccine is available and it is safe, efficacious, and give more than 90% protections and lasts for more than 10 years. So with this, I think we have a very solid data that we can carry along with us tomorrow onward to our clinical practice and try to identify those who are at risk and try to vaccinate as much as we can. Of course, we might encounter vaccination hesitancy, reluctancy, and vaccination fatigue, but this is our role as a family physician and primary care to take this challenge and to promote whatever is right for our patients and our nation. With this, ladies and gentlemen, I would like, on your behalf, thank our guest speakers for their wonderful contributions. And I would like to thank you for being here with us today. And I would like to extend our thanks to GSK Company for the wonderful contribution to get us, all of us together here. And a special thanks for Fexus Company for the wonderful organization. With this, I wish you a very good practice and I wish you a very good night. So now we will go for dinner. Where is the dinner? Basement? Okay. Thank you very much for all of you.